course in pediatric palliative care. I'm Dr. Spandana. I'm the facilitator for today. I'm a pediatric palliative care physician and trained in Hyderabad. So it's a privilege to introduce Dr. Gayatri and Dr. Archana. Uh, Dr. Gayatri is a very, very senior pediatric palliative care and even adult palliative care expert. And I think we are very lucky to see to be part of her session because even though end of life is not what pediatric palliative care is all about, I think it is one a very challenging situation for all of us. And to hear from the experts, where we have a huge pediatric palliative care program in Hyderabad, I think we are privileged for that. Dr. Gayatri ma'am, over to you. And we also have Dr. Archana Iyengar, who is currently leading the pediatric palliative care in Hyderabad. And again, between them, they cover two tertiary pediatric and cancer hospitals and see a huge number of pediatric patients. So I think we are in for a wealth of information and also experience in the next few minutes. Over to you, Gayatri ma'am and Archana ma'am.
Thank you very much, Spandana, Dr. Spandana, for kind introduction. I also want to say that in today's session, we are also having a very special privileged guest joining us, Dr. Biplav. Dr. Biplav is a pediatric palliative care physician joining from Kathmandu. Actually, he's here in Hyderabad. So he's spending time with us, and so he's also sharing one of the case which he saw during the presentation. So thank you very much for that. So maybe I'll start by sharing screen from my end, if you allow me. Yeah. So Dr. Spandana, can you see my slide?
Yes, ma'am, they're visible.
Okay, thank you very much. So very good afternoon to all of you. And as Dr. Spandana mentioned, today the topic of discussion is caring for children at end of life. And as Dr. Spandana mentioned, as a pediatrician, all of you are dealing with seeing children every day in your practice, day and night. But even for adults, like I come from an adult background, we don't see how actually children are dying, because most of the time they are in their homes. Once, especially children with life-limiting conditions, once we diagnose, we say, okay, nothing more can be done, and they go home. And finally, what happens in the community, in their homes, is not really we witness every day. And so the whole discussion is about how children are dying, and how can we do better with the job of taking care of such dying children. I thought I'll start with sharing this story of a child. This child, Asra, a name change, sorry, I meant Asra, 5 years, relapse ALL, and on chemotherapy, ALL relapse protocol. Suddenly she developed bleeding from the nose, seizures, and shortness of breath. Because of this sudden event, she was shifted to intensive care unit. Saturation starts falling. She could not be maintained on oxygen, room air. There was a need for ventilation. She was ventilated. Within a day, she died. Family were very upset. They were very upset. They did not expect that the child would die so suddenly, and they did not expect the sequence of event. So just by simple this hypothetical case study, and we'll discuss more around actually this actually happened in our ICU, and we're so when you look at this kind of presentation, I'm sure this you see every day in your practice, relapse condition and developing complication and dying in ICU. What went wrong, do you think? Or do you think it was a good death? When we talk about death, it's all about this, as today's discussion is all about death and dying. Do you think the child had a good death? When it was known that this child was having relapsed ALL. I want to hear from you in the group, if we can just put it in the group to have for the sake of discussion. Yeah, I see Dr. Gopi Krishna saying counseling. So obviously you're feeling that maybe enough counseling did not happen or adequate counseling did not happen, because most of the time we do counseling. I'm not just, I worked in intensive care unit, and I know that all the doctors do spend significant amount of times doing counseling with the family, preparing them, but still often they feel that they were not told enough, and there's a gap, and they become very upset. Obviously, Dr. Sangeeta feels that now this family definitely they needs bereavement counseling, not just the counseling about what was going to happen, also because the way it has happened, they definitely need bereavement counseling. Absolutely agree with you. Anything else which you think was not so good about the way that there was this turn of event and the way the child died? Would you Sudden death happened because of bleeding, yes. It was expected for the diagnosis. Family should have been prepared. Same. Absolutely, I totally agree with you. Yes, this is what is required. And probably they did not understand the context. I also see Dr. Vijay Lakshmi, no matter how much we counsel, the family may not be prepared for such a first event. I absolutely agree with children dying is not something easy to accept, and however much you tell, sometimes the family still find this as a unexpected event, sudden course of event. Absolutely, I agree with Dr. Shubhi, and how the child died. Acceptance, it's a matter of whether how much the acceptance was there in the family. Yeah, but then how about the child who died? Was that a good kind of death? Yes, Dr. Swapnanil, I totally agree with you. Was there a need for ventilation in this child? Was it justified? I don't know. I'm just thinking from a critical care point of view. Was there any justification for ventilation in this child? Death not to be looked only from suffering of patient part, but for caregiver part. A lot of spiritual faith and mental preparation of family is good. Absolutely, Dr. Kunal. I don't know what is the. We often say death is for the people who are left behind. So the patient dies, and for the family to deal with the spiritual distress, suffering, and the faith and the mental preparation, which often goes unprepared, and that leads to so much of suffering. Absolutely. I'm so glad that just with this small case study, you came out with so many responses, with all of which are so important when you think about dying, and especially dying, a child dying. So I was just thinking about it. Was it a really good kind of death? And I asked myself these questions. How adequate was Asra's symptom control? So Asra was suffering from bleeding, seizures, shortness of breath. Is there an only way of managing symptom, like just putting the child on ventilator? Is a question asked. Was there any better way we could have done it in terms of symptom management? I still see some responses coming. Someone is saying relapse case, parents must be well aware of consequences. We always hope that the parents are aware, but sometimes it may not happen, as we'll discuss more. I recommend that iPhone 2, if you can put your name, because this is important for our attendance also. Thank you. Thank you very much. So the one important aspect which came here, which I thought was not done well, was symptom control. Then, as some of you pointed out, what is the rationale of mechanical ventilation when you talk about terminal conditions? How much it is justified? There are several studies which have shown that mechanical ventilation is not justified, and the outcome is really poor when you opt for mechanical ventilation in these kind of patients. So could we have avoided mechanical ventilation? That's another question which we can ask. Parents, how we've always, as I said, we think we have to explain everything to parents. Why can't they understand? But very often, as many of you mentioned, accepting child's death is not so easy, and parents were not, obviously here the parents were not prepared, and that led to this kind of often leads to conflict. And as Dr. Navreet Kaur mentions, parents could be given option. Yes, was there a choice for the patient to go for this kind of approach to end of life care, or we gave some other choice? Was there any choice for the parents to opt for this kind of under these circumstances? And very important, I thought, what about a child's wish? What was child's wish, considering the child was really end of life care? What's the quality of death? This is what the good quality of death, dying in ICU with all the tubes down the throat and all possible orifices in the body, away from parents, away from family, not getting that one last hug from their parents, and not spending time with the siblings. Was it really a good quality of death? Something which left me thinking. Defining the end of life care period. We say that end of life care period is a period of when the child has no realistic hope for cure. But often this is, we don't know what is, some people say end of life care means last 24 hours. Some people say 48 hours, or some people say last 6 months. So it's all often debated, like what is end of life? What do you mean by end of life? And often it is variable, and very often it's retrospective diagnosis. Oh, this child was actually end of life. When the child dies, finally, when we realize, oh, actually, all these problems were probably the child was towards end of life care. So it is difficult to define, but still there are various ways we can look at it. But before that, I want to understand, we all deal with death and dying. Often, what finally the end of life care most children receive are not adequate. Various studies have shown, and it's the same. I'm pretty much sure in India too. The children with life-limiting conditions, often they don't get good end of life care. Why do you think this challenge? I see one response from Dr. Vijay Lakshmi. It's a matter of dilemma for treating doctors when we are questioned if we have done everything in such situation. Absolutely. So this dilemma, Dr. Vijay Lakshmi, this dilemma also comes from not just the family asking us this question. Our own dilemma, have we done enough? And this stems from what we call it as prognostication. When we don't know the prognosis, we don't make a good analysis of, good sense of the child's condition and the prognosis, and that leads to a lot of uncertainty, and we'll end up taking not a appropriate decision. Yes, so one of the reason why we don't, the children don't get good pediatric end of life care is that difficult prognostication, and always this question: have we done enough? I see one response like Dr. Rosina explaining, there's a lack of manpower and other resources too, absolutely. But when we say lack of manpower, ICU care is very expensive. But how come we'll end up having all the children going to ICU and spending more money when we say lack of manpower? That's something we always think about. Awareness, yes, absolutely, Dr. Swapnil. We have so much little awareness about end of life care, and there's another way to look at end of life care, not just ICU care. There's another way to provide good end of life care. So these are some responses. Absolutely, I agree with why there are challenges about providing good end of life care. Like I just put on my own thoughts. Like children on first thing we all agree, children are not supposed to die. It is against nature that a child is required to grow to become an adult and then die. But here a child is not such a small child. How can a child die? For us as a physician, as you already mentioned, death of a child means we have not done enough, as if our therapeutic failure, and we always search for, I want to do best possible to take care of the child. Dr. Swapnil Neil also mentioned that it's like a protocol for us, like if a baby is dying, have to intubate, have to ventilate. Yes, absolutely. Somehow we have our own protocol, not even questioning whether how much scientific validity to this approach that all child should go to ICU and die. Dr. Kosina says that most parents, when they hear that the child will not get better, parents want to go Lama. It's worth thinking about, worth giving a food, like a thing to think about it. Why do they do that? Why do they go Lama? Yes, maybe they want to go home once they realize the child is not doing well. And once they say, the moment you tell them your child is not well, parents, then that is the case, I want to go back to my village. I want the child to be with my family, siblings, let him die there. Actually, if you ask me, that's the best way to die, provided we are able to give comfort in the home. That's the reason we say pediatric care is care which should be provided to a child whenever they want it, wherever they want it. So ideal situation, I'm talking about ideal situation, a child should get a pediatric palliative care whenever they want it, whichever stage of the illness and wherever they want it. So when they go on LAMA, often the reason I think is because they want to go home and be with the family and spend time with the siblings. So if can we provide palliative care if that is the case in their home setting is something often we ask. And I think when you look at the case study, we'll understand this little more in detail. I also accept Dr. Kavita's response that childhood mortality is not accepted. Yes, we believe child should not die, and we want to do everything possible to keep the child alive, and that leads to a lot of this conflicting information and not so appropriate care. Surrogate decision making. So often the decision is made by someone else. We never take into account what child's wishes are in this context. Prognostication, I'll come back to that again. Communication, often there's gaps in communication, and we did have a session around communication, and we realized that often we think that we have done a good communication, but family, they don't get it. And of course, one important reason why every time we get into this mode of going to ICU care is because always we think, are we right ethically? Are we right medico-legally? So sometimes this forces us to make this kind of irrational decision, which may not be always in the best interest of the child. So these are some barriers to why the children, they don't get good end-of-life care. I think you must have seen this graph, and maybe in one of the introductory sessions, like how, see, in cancer, the trajectory is much more easier. You have cancer, you live for a period of time, there's a relapse, and then there's a sudden decline and you die. The problem comes when you look at other non-cancer conditions, like other cardiac, neurological conditions. What happens is that the child, as they live with this life-limiting condition, they go into some crisis. As you see, there's a dip. Then they go to the hospital, they get the best supportive care, best treatment, which need to be given to address that crisis, and the child recovers. And the child goes home. Again, the child develops crisis. Again, there's a dip. Again, they rush to the hospital and they recover and they go home. And this goes on and on. But what we don't realize is that, we don't know in which of the dip the child may never recover. So the child may never come around and the child may die. Second, if you see this graph, not only there's a dip, there's also gradual decline in child's condition. The child's overall performance status is coming down, and one of these declining conditions and one of those dips, the child suddenly dies and death happens. So problem is that when do we initiate this discussion? This child is not doing well, so we have to think about good end-of-life care. So that is a challenge we all face all the time, and often that leads to conflicting information which the family gets, because a physician in ICU will say, no, let me try. Last time the child came around, so maybe this time let me try once again some effort, and child may recover. And here we are thinking this time child's general condition is very poor, may not come around. We need to initiate this conversation. So the general consensus here is that when you see a general decline in child's condition, along with this frequent hospitalization, it's time to initiate this discussion about palliative care. So it should be need-based. If the child has symptoms, yes, they need palliative care. And also when you see this general decline. And because what we have to remember is that as a pediatricians, I'm sure all of you work with this principle, the principle of best interest. The pediatric healthcare is practiced with the goal of promoting the best interest of the child. And best interest in this child is how do we assure this child is getting best of care. One approach really helps us when to initiate end-of-life care discussion is asking the surprise question. Would I be surprised if this child died in next 12 months? If your answer is somewhere yes, I think you should start thinking palliative care and start looking around for palliative care support, or you yourself providing palliative care. And then your focus of care gradually should shift towards improving quality of life and comfort. And this is the standard practice, and it's in the best interest of the child. So with that principle, I think we should look at the entire end-of-life care. And once a child is decided on that this child's general condition is declining, and I think this child may not live long, and we should have this flexible care plan. If you look at the left side of the picture, if the child condition is life-threatening and that is not expected, but child is declining in NICU or in a critical care unit, not just in NICU, anywhere, then it's time to engage the multidisciplinary team of palliative care and think about transition to palliative care program, which may be in the hospital, in the home, or in the hospice. If the child is in ICU already and the child's death is imminent, then you have to think about the end of life care right there in neonatal or palliative care unit, ICU unit in the hospital itself. Think about plan for compassionate extubation if already done, or if it is not done, non-escalation of care and providing palliative care in ICU. It's a very new concept, and more many hospitals are taking this approach, providing palliative care in ICU itself. And because if the child is not doing well in the ICU. So these are two approaches. If the child is diagnosed with condition where you need palliative care getting involved and defining where they're going to and transition to palliative care. If the child is in ICU already and dying, then think about providing palliative care in ICU. So to do that, the most important thing then, it all boils down to communication, because as you mentioned very correctly, often the family's problem with acceptance, family not accepting, family not prepared, all this issue stems from the very basic problem of inadequate communication. And so when you're approaching the family with your intention to communicate, please remember one thing. Very often, the family is already physically and emotionally exhausted, going to multiple hospitals, same hospital, multiple admissions, and many other psychosocial issues happening in the background. And they're usually very young parents. When you're dealing with pediatric population, we're dealing with young parents, no experience in death and dying. And it's not easy for them to comprehend and take complex and distressing decisions easily. You tell them, this is not happening, that is not happening. So do you want to go for DNR? Do you want to go for ventilation? All these are very complex and distressing decisions. And they may not be able to take in one sitting, or they understand what you're talking about. So when you're planning for communication, please plan your session well. Planning means you have to decide, fix up a time, call the family for a meeting, find this kind of quiet place. You may not have fancy rooms, but can you find a corner where you can sit down and talk to this family? Because for them, this is a very important life-changing event going to happen. So we have to be respectful of that. Encourage as much as possible for family to participate in decision making. They need to have the sense of control over their parental role. So how much is that can we provide in decision making? And to have a consensus and informed decision making. That means they are informed and then they make a decision. And with the consensus, the biggest problem happens is when we don't share the information in a language which they don't understand. So we have to provide the information in a language which is simple, clear, which they can understand in a sensitive manner, and which is aligning with their beliefs and values. It has to be culturally appropriate. So all these things, you have to take into consideration to have that informed decision and in consensus. And now to achieve this, sometimes you may need multiple sessions and you may need help of multidisciplinary. Many discipline members should come together, because you initiate the discussion. You may need to have the follow-up with taking help of your social workers or your nurses or your junior colleagues who can follow up with the discussion, because many times they'll have several doubts, several questions. They want to come back and ask you. You must give them the opportunity to do that. Some of the phrases which we use, sometimes it's not helpful for the family. When we say withdrawal of care, it's like we are giving up or abandoning the treatment. And so when you ask them, I'm going to withdraw this care, and when you ask the family to give permission, the family feel it's like as if you're asking them to terminate their child's life. And they live lifelong with that guilt, if it's somewhere, if they agree also. So such phrases may not be helpful. The phrases, what will be helpful is focusing on what is that you can offer than what you cannot offer. The focus on what will be rather than what will not be provided. Phases such as the focus of our treatment is to keep the child as comfortable as possible as long as she lives. So you're not talking about what you will not do, rather you focusing on what you can do, or focusing on providing dignity, or focusing on what is that, let me see what I can do to keep your child absolutely pain-free as much as possible. So when you focus, you shift your focus to what you can offer, it's much more helpful for the family. And meanwhile, when you remember the situation when you feel that this child does not have a lot of time left, you have to start making this advanced care planning. So the Asra's situation, when the Asra was diagnosed with relapse, the advanced care planning should have been in place. And what you mean by advanced care planning is making a medical plan well in advance as to how the medical care is going to be in future, considering that Asra is having relapse. So to do that, we have to discuss many aspects such as, suppose Asra's condition deteriorates, are we going to resuscitate? In the event of resuscitation, withholding or discontinuing certain aspects of care such as intubation, mechanical ventilation, and whatever you discuss in terms of advanced care planning as to what to do in the event of Asra's condition deteriorating. And that goal of this advanced care plan must be documented and shared with our entire clinical care team. Now, this is important because you make a great discussion with the family and reach a consensus that will not go for aggressive treatment. And you document it also. But if you're a doctor who is on night duty, if they're not aware of this and they just don't see the documentation, and if they decide to go for aggressive treatment, that can lead to, again, conflict of information as well as decisions made. So this is something we had to remember, that how you document and how you share with all clinical care team, nurses as well as doctor. Then again, when you talk about code status, discussing about DNR or not to go for aggressive treatment, it's always helpful when you do this advanced care planning to have some create a hypothetical circumstances which is helpful for the child and the family, and then discuss the prognosis and elicit understanding, and then based on that elicit goals of care. Now in Asra's situation, Asra, when Asra was maybe if is diagnosed to have advanced relapse, we'll create this hypothetical situation. Asra is not now looking absolutely fine. What tomorrow, because of a relapse, if I hope you understand, first of all, discussing the diagnosis and making sure the family really understands. And then go to the next level, creating that hypothetical situation that what if the Asra suddenly tomorrow starts bleeding? If that is the situation, what should be our approach to her care? That's where you start discussing the advanced care planning and the code status about not to go for aggressive treatment. And gently, what you have to recommend is that what is ideal for her in that situation and what will not be good for her. So this is how we initiate code status or discussing advanced care plan. Any thoughts around this? Dr. Spandana, you and Dr. Archana, you must have done many patients with this kind of situation. Anything you want to add to this? It's a difficult discussion, discussing the code status or not to go, DNR status, not to go for aggressive treatment. Is anything which you thought you found helpful when you're doing that?
Ma'am, one thing I think all the doctors must be thinking about is it even legal is one thing I think we all think about. And then having the whole team be on the same page is the other challenge. So if you can just address how we do that and how we are all on the same page and how do we even decide all this is something I think pediatricians would always wonder about.
Absolutely. Thank you, Dr. Spandana. So this legality issue, yes, it's a very big thing, which we must all be aware. What is the legal status of this kind of situation in our country? But this is the situation we are doing much before the actual act of putting the child on ventilator, not to go for ventilator. So what here is a situation where we talk, when you say advanced care planning, is when first you recognize that Asra has relapse. that's the time when you have this discussion, and we're discussing the goal of it. We are looking at what you call is what is the scientifically, or what is the evidence, current best practice. And the best practice under these circumstances is comfort care. So you're choosing an option which is the recommendation. So you're not choosing, and we are not doing away with the option which is not recommended. We're choosing an option which is recommended. That is the best practice. When we identify a child with relapse, and when you understand that this child does not have a lot of life remaining, to go for comfort care is the recommendation. So that is legally absolutely acceptable. Legally, anything futile, when we talk about futility of care, a treatment being futile means a treatment which is not going to give minimum therapeutic effect, minimum therapeutic benefit, is considered as futile treatment. And legally as well as ethically, it is acceptable not to go for such futile treatment. So ethically, legally, both ways, and scientifically, when you look at the evidence, the best practice is when a child is diagnosed with relapse condition or life-limiting condition, the best option is to go for comfort care. And this is absolutely acceptable legally as well as ethically. But the task is then how to involve all the healthcare workers who are involved in care of Asra, a child like Asra, that they all are in consensus about this. That is a task very difficult to achieve, but maybe one-to-one dialogue is something which always is helpful in such circumstances. And very important that you document this. When you discuss this, the important thing, what finally protects you in the court of law is how well you document the discussion. What is the discussion you had? What is the prognosis you indicated? Whom did you discuss the discussion? Initiate the discussion? Whom did you have this discussion with? And who all were present? And what was the consensus reached? Were there any issues that remain unresolved? Everything, if you document, and that is going to protect you in the court of law. No amount of signature or consent is going to protect you, but this is what is going to help you in the court of law. So coming to the actual help a child like Asra, what we could have done to actually providing end-of-life care. First thing I would say, actually when the child is in a dying phase, and actually the child is dying, one thing which as a palliative care, what is that we do to take care of such patients? What we start with is impassible assessment of distress, because it's all about comfort. So how do you measure comfort? We have to measure comfort by looking at the symptoms, because we are not looking at here more investigation to measure comfort. Comfort cannot be measured by investigations. Comfort cannot be measured by monitoring of putting ABG analysis or sending for blood. Comfort is measured by symptoms. So there are some standardized scales which we can use to measure symptoms. Like I'm sure pain scores, various types of PIPS, NIPS, and neonatal pain scores are already discussed. And there are some agitation and sedation scales which we can use to measure comfort. And of course, using all possible non-pharmacological approach to reduce pain and distress, and medications to relieve distress. And this is the core part of when we say comfort care or end-of-life care. When you provide this, the end result is the child is comfortable, family is comfortable, and the family will not go for Lama approach, or they'll feel so satisfied that this is what I want for my child. And this should be core part of our whole approach. And like I said, always monitor for distress. Like distress, we can monitor by looking at the symptoms: change in breathing pattern, moaning, gasping, excessive secretion, dry mouth. All of these things can be just observed and actively look for this distress. Ensure warmth and comfort when we say comfort care, and continue to measure distress. I'm not going to detail of these medications. We'll be sharing this presentation. So the common symptoms which we see in end-of-life care is pain, seizure, agitation, secretion, and dry mouth. So these are the different medications which we use. Go very actively looking for distress and managing these symptoms. And some of the terminal events which we see, again, like I said, bleed, dyspnea, delirium, pain, and seizure. So again, we have to go back and look at these medications and the dosage required to manage these problems. And while we are doing that, listen to the family. Listen and listen to what they're saying. What do they see? What are their worries? What are their hopes? And where do they want the care to be? And do they feel comforted? So this is something which we should closely monitor while all this symptom management is happening. So you can ask, it will be helpful to ask questions like this. Tell me what you're seeing. So you've been with your child since morning. How do you feel your child is doing? I see that the child has not been eating for several days and her body is weaker. What do you see? What do you feel about her condition? So listen to what they're saying. And maybe you can gently tell them, this is what I see is happening to the child. I see there are signs of dying, because family often ask, because they won't have seen a death before. I've seen many families asking, so how is that going to look like? How would I know that my child is dying? So we say, these are some signs of dying. There's more and more decreased need for food and fluid. The breathing pattern changes. The breathing will become more shallow and irregular. Slowly, your child's urine will stop coming. Output will be very less. Your child's extremities will become cool or gray, and the color may change, may become pale. So these are all signs. If when you see, it means that your child is slowly dying. So this is a very painful discussion, but when you give the opportunity, the family, they want to know, and you can facilitate this discussion. But reassure them that, yes, these are all happening, but at the same time, we are actively looking for any distress. And looking at your child, because there is no such distress, I feel your child is very comfortable. And if you sense the child is not comfortable, immediately have this care plan and go up on your medications. While doing that, the family feels very frustrated. I have to do something, because that's what they want to do something, and they want to feel useful to take care of the child. So we can say, again, shift from what they cannot do to shift your focus to what they can do. So some of the things you can suggest, like these are some of the things you can do to help her. Hold her hand, keep her mouth moist, sing a song for her, tell stories, or just simply touch her and say, I'm there for you. Don't worry, I'm here with you. So they feel something, they're doing something very meaningful. I wonder if you want to contact your family. Do you want to call your siblings? Do you want to call her siblings? Do you want to call her grandparents to come and see her? Why don't you hold her and take a picture for you? This is a very important, precious time you want to spend with your child. Maybe you want to hold this as a memory. Some families, they may want it, some family may not, but offering these, so doing things which are more meaningful and to the child is helpful. Some of the statements which may be helpful, especially when you're dealing with older adolescent and young adults, you can encourage the family to say, please, you can say, I love you, forgive me, I forgive you, I'm proud of you, I'm always with you, you're always you can facilitate the family to say. Now, this is one aspect which is very painful. Often this nutrition and hydration and end of life is a very painful discussion, and they often there's a lot of again differences, and often we have to first of all understand that this is not helpful. When a child is actively dying, continuing nutrition and hydration often leads to more harm than doing good. Other than the painful procedure which you subject the child to, too much of hydration can lead to more of secretion, pulmonary edema, and the child is very fragile. They become more breathless. So we have to initiate this concept discussion. And again, focus the attention from what you cannot do to what you can do. So offering small sips, taste of flavored liquids and food, and keeping the mouth moist. So keep the family engaged with doing something which are more meaningful. And make the little time they have with the dying child, memorable. What you can do is doing things like allowing the family to hold the baby, kangaroo care, rituals, naming the child, because in the process, they may not even remember to name the child. They'll be calling baby of Asra, something like that. So reminding them to name the child, maybe it'll be for them to remember that I had a girl, baby girl, her name was Asra, and any other religious ceremony, bathing and caring for baby's body, feeding, laying down, just lie down with the baby by the side, taking the baby outdoor to show the sunshine, or allowing the siblings to hold the baby. And some of we call it as making memories. photographs, videos, hand and footprints, molds, keeping the personal belongings of the baby in a small keep. Maybe we as a healthcare sometimes we facilitate all these things, and keeping a small hospital items which can remain as a memory, we can put it in a box and keep aside and hand it over to them. Some of the things after death, very important, equally important. It's not that when your baby is dead that we leave the hall. No. First of all, some things we have to do respectfully is confirming the death and bringing out with simple statement like, I'm sorry for your loss. Your baby is dead. You have to say it very clearly. We name it that the child is dead, and then say, I'm sorry for your loss, and document the date and time. Of course, we'll all the medical record, which we all do all the time, allowing the family to be with the body for time, because for them it is very important to spend that precious time, and they may have some cultural or religious rituals they would like to do in the under circumstances, allowing that to happen. And very important, like I said, the families are very young parents. Often they don't see death and dying. They may need a lot of practical help like death declaration, mortuary, ambulance, funeral services, and where to find death certificates. So put our social workers on job and they can help with that. And very important, these families, losing a child is one of the most difficult event of a life. They definitely need bereavement support. And one of our doctors in the beginning itself mentioned that. And we have to actively look for what we call it as complicated grief. Many families, they get into complicated grief, and they need real psychiatric and mental health help. So we have to actually look for such families and support them. And very important thing for us, dealing with death and dying is not easy. When we repeatedly face this day in and day out, we also undergo a lot of what we call it as burnout, compassion fatigue. So it's very important that many of these difficult deaths, sit down with the team, have a debriefing with the team session, and see how they are doing with dealing with this, and supporting each other is something important part of the final part of dealing with it. So put it all together, caring for children end of life care. We have to identify children who are approaching end of life, make an advanced care plan, recognize imminent signs of death, providing emotional psychosocial support which is required, managing distressing symptoms, address the hydration and nutrition needs of the child. Sorry. Hello?
Yes, ma'am, we can hear you.
My slides?
Yeah, visible, ma'am. Yes.
Sorry, I think I lost it somewhere. Can you see my slides?
Yes, ma'am, we can.
Yeah, they're visible.
Sorry, just a minute.
Gayatri ma'am, we can hear you, see you. The slides are visible.
And then planning communication. Now, this is important. Sometimes the family says, I want to take the child home. There must be proper communication between the services, care transition, care coordination, providing out of our care. And we're going to discuss this as we discuss the case, and supporting each other, not only the parents and healthcare professionals. So this is something briefly, or rather a little detail about taking end-of-life care in children. So Spandana, we have two short case studies just to make a point. Just to make a point about whatever we discussed. So we'll take some quick questions before we go to the case studies.
Yes, ma'am. I think you have covered everything that has been said, but there is one question which they're asking: if we stop monitoring vital signs in the children during end of life.
Okay, a very good question. Often, like as a healthcare professionals, we find it very difficult not to monitor vitals. Yes, but I'll ask you, what I always tell my team is that when you're taking care of end of life care of a child, what is our goal of care? Yes, the goal of care is comfort care. So whatever we do in terms of intervention or care, we have to ask this question: is that going to add to the comfort of the child? If I'm measuring the child's blood pressure, I know that the blood pressure will decline over a period of time in end of life care. Pulse will become feeble. So if I measure, what is that I'm going to achieve by doing that? nothing. So I'm not going to correct her blood pressure at that point of time. And if her pulse is feeble, I'm going to put her on inotrope. No, I know there's a child is dying, and we took this stand. There's this child. We are always looking at as comfort care and best supportive care. And that's if that is a agreement. Then we look. Our focus should be what is that I can do to improve that, to achieve that. And so for that, I'll monitor breathing. Definitely, I'll monitor breathing. That will be one vital I'll definitely look for, because that is a direct indicator of the child in distress. I look at a breathing pattern. I look at symptoms, like how irritable the child is. Is the child confused? Is the child is in pain, grimacing and moaning, groaning? Is the child having a lot of secretions? These are the few things which I'll monitor, then monitoring the vitals. You can monitor, but it's just add to the distress of the healthcare worker when they see the declining blood pressure or pulse rate changing rate and the volume of pulse. So that's how we would approach. So,
ma'am, I have a question. Some of them might be hesitating to ask. If you're doing this day in, day out, talking about end of life, stopping monitoring and handling children who are dying, which is, as you said, very unnatural. Did you ever face violence, and is it a reality that you have faced?
So, very good question, Spandana. I would say yes and no. Like in our hospice, in Mandara Hospice, where we have a hospice, children's hospice in Hyderabad. We call it as Mandara Hospice, named Mandara after a flower, where we see children every day. They come for admissions and they die there as accepting that end of life care. So most of the time when they are coming there, their preparation is such a way that the family is in acceptance and they come with that. And often the death is very peaceful and their family feel relieved. And we never see conflict. The conflict arises when the referral and our intervention, we don't have a lot of time. We are not given a lot of time. When you don't get a lot of time to prepare the family, so today you get the referral, tonight the child is dying, and we get few hours to prepare the family, and suddenly this transition is something family find it very difficult to accept. That's the time we have seen that there's a lot of agitation and a lot of family getting very upset about the whole event. Suddenly the primary doctor, the treating doctor, they feel that they are let down. They're abandoned by the treating doctor. Suddenly they're being asked to see by another team, and this team is saying no aggressive treatment. So they feel all this very confusing, very lot of conflict and arises from this situation. So the response from the family is always better, much more accepted when we have an early referral and enough time to prepare the family and the child as well, understanding child's wishes and concerns. Spandana, what is your take on this experience?
Ma'am, as you said, if we go in the last minute, I think there is always this question of trust and what is this new person talking about. But again, if we have at least few days to work with them, at least few hours to work with them. In my 6 years in Hyderabad program, where I think we provided children, hundreds of children with end-of-life care, luckily we have never faced violence, and we even adult also, I think it was always about preparing in a very calm situation, and even before the crisis happens, so that the family is prepared for what is coming.
Absolutely. Thank you very much. That was very helpful, Spandana, to share your experience. I also see Dr. Bipla's response that even things like putting saturation probe with the tape on the finger and ECG probes, leads on the chest with a lot of sticking around, is not comfort for the child. So little things and putting an NG tube and sticking the plaster on the nose and putting that CPAP thing on it's all very, it's not comfort. So we have to see how best we can minimize all the sources of discomfort. Yeah, thank you. So I just want to go to one quick presentation. Dr. Archana, if you can just, maybe I'll just stop sharing and see you first before I share, before I put the slide on.
Yes, ma'am. Thank you.
Dr. Archana, can we see you? Yeah, thank you, Dr. Archana. So shall I share the slide?
Yes, ma'am, sure.
So Dr. Archana is a very senior pediatrician with pediatric palliative care who has done pediatric palliative care fellowship, and she's working in our program. And she's going to share one real life experience of dealing with end of life care in non-cancer condition. So let's see how what she did with how she dealt with that in her practice. Just tell me, Archana, when to move the slide.
Yes, ma'am. Thank you, ma'am. Yes, ma'am. So, good afternoon, everybody. So, this is about a 11-month-old boy who was admitted to a tertiary hospital in Hyderabad with a complaint of abdominal distension and shortness of breath. Unfortunately, the child was diagnosed to have extrahepatic biliary atresia beyond 6 weeks of age, and it was too late for a Kasai procedure. So, the child progressed into liver cirrhosis and liver failure. The child also was explained initially at the time of diagnosis about poor prognosis. And when the next slide, please, ma'am. So when the child came at 11 months to us, the child was sick looking. The child was very restless. The child was admitted in the PICU in view of the symptoms. The child had a Downey score of 3 with respect to respiratory distress, and a distress scale of 3, FLAC-R, that we measure in palliative care. And the child also was delirious with a scale of more than 9. Next slide, please. So since the child was in the PICU directly for 5 days, to relieve the shortness of breath, there were multiple ascitic taps done. The child was also on oxygen with a face mask. However, investigations done daily were suggestive of the child deteriorating with increasing levels of prothrombin time and ammonia. Next slide. So in view of deteriorating clinical condition and also lab parameters, referral was given by the PICU team to us to support them in the family counseling and also delivering end-of-life care to the child. This was done on day 5. So we arranged a family meeting and spoke to the parents and extended family in detail about the prognosis. The goals of care for the child was established, wherein main priority was comfort care. It was a shared common decision that was taken from the family after we discussed with them. A care plan was made for the treatment of further management of the child. There was also a crisis plan that was made, and also the parents and the extended family were spoken about a death care plan. So in the same time, we also communicated with the pediatric ICU team regarding the management in the best interest of the child, so that both of us were on the same page. And thereafter, all further investigations and blood product transfusions were withheld. So we didn't want the parents to run around getting blood or going and giving the investigations in the time where they should be spending the precious time with the child. So also when we spoke to the family and extended family, we decided about the place of care, where they wanted their child to be in. So also options of hospice and home care was given, because we have a home care team who goes and visits daily in case a child is in end of life. However, the child, since they were far off from Hyderabad, they preferred to stay in the PICU. And because the child was too sick to be transported, they didn't want to shift to the hospice. Also, we had to speak to them on do not ventilate, and consent was taken on do not resuscitate. So coming to the pharmacological management for the symptoms, the baby was given morphine at 0.1 mg per kg, mainly for breathlessness every 8 hours, and also SOS. During end-of-life care, we can administer this even hourly into the buccal mucosa. So IV fluids were stopped after again communicating with the parents, and we explained them about moistening the lips if required. The main goal was to keep the child comfortable. So the child was made to sit on the mother's lap. And if possible, we can see that the room is well ventilated, and even keep moistened cloth on the baby's cheek so that the baby will get a little cool air. And if possible, there are small fans which are available, which can be just, the face of the child can be exposed to the small fan. We also took permission from the PICU team so that the father could be allowed in to the ICU and be bedside with the child and the mother of the child. Since the child was very restless, we also had to give Allorazepam 0.05 mg per kg sublingually, and also saw that the child was comfortable in the mother's lap. In anticipation of an emergency of hematemesis or melena, a bleeding kit with necessary medications, gloves, and colored towels were given to the child and family. And the distress scale, as mentioned already, was monitored every 4 hours so that the child was most comfortable. Our pediatric palliative care nurse and counselor stood by the young parents in this tough time. And the child passed away on day 6 peacefully. Thereafter which our counselor helped the family with the paperwork, transportation, and funeral services, as ma'am already mentioned, which is important and difficult at that time. And thereafter, because they were away from Hyderabad, we had a bereavement phone call follow after a week of the child's death. So this was a child with extrahepatic biliary atresia in acute on chronic liver failure, who was given end-of-life care in our tertiary hospital setting. Thank you.
Thank you, Archana. Beautifully presented. So some of the things highlighted here was like the child was having life-limiting condition. Like, remember we discussed about the triggers for pediatric palliative care. This was a classic example where the child definitely required, a child was having life-limiting condition, not expected to live a normal life. And it was very early on, it was referred to pediatric palliative care. Scales were used to measure distress. So if you remember, if you see, she used scales like FLAC-R to measure pain. She used what else scales did you use, Archana? One is FLAC-R.
For FLAC-R, for distress we used. For respiratory distress we used the Downey score, and Cornell assessment of delirium for the delirium and restlessness and agitation part.
Thank you, Archana. So why do you think it's helpful, like for you using this kind of scale?
Since our main goal of care is comfort care, we have to subjectively assess the child's distress, and only then we'll know whether we are really giving the comfort care that is required. So sometimes at end of life, maybe we really need to monitor even every 2 hourly the scale so that the child is given utmost comfort as possible.
Thank you. So this was a classic example of death actually happening in ICU, but with the support of pediatric palliative care. And I also noticed one important thing, that how shortness of breath, which was a predominant symptom, and pain was screened on regular basis, so that throughout they looked for distress and they were ready to anticipate distress and manage distress proactively. So that was very effectively, I thought it was covered. Spandana, we didn't put questions. We just thought it'll leave it open for discussion. So any thoughts around this kind of scenario which you see in your ICU, and what would you have done? You could have done to make it better, or do you think anything you want to add to this? How this was handled?
Ma'am, sorry, I meant the questions from the participants.
Okay, sorry. Yeah, sorry. Yeah. So, sorry. Thank you, Spandana. So, feel free. And I'm sure all of you are very senior practicing pediatricians and you're seeing such patients every day. And would you like to share your experience of similar situation in your ICU where it was very helpful?
Hi, ma'am. I'm Dr. Shraddha. I'm from Maharashtra. I would like to share my own experience. I'm pediatric hemato-oncologist. And yes, we do deal with such scenarios and situations. And when I was doing my residency from Wadia Hospital, so I want to share this experience of my own for everyone to understand. When we deal with such situation, it is not only that we need to take care of parents and child, but at the same time we need to take care of our own self, because there was one situation had happened that we had 3-4 relapses, 2 kids who were on just a deathbed. Like, we were just waiting, the parents were waiting, when can we take this child home? And the total in a day I had done 6 counseling of such sort that now we just have to wait and watch. We can't do much. You have done maximum, the best you have done. Now we will pray, all that sort of. And with as the counseling were going on session, like the first parent, second parent, third parent, gradually I had my own breakdown that what I'm doing, what I'm dealing with. Have I become a doctor just to tell that we can't do much, and that is what we are going to give? So like, even if this is a palliative course and we are practicing this palliative medicine, but I would like that we should also take care of our mental health when we are practicing daily all this type of counseling, because somewhere it gives a negative impact on our own health also. So there is a question also, like, I would like to ask, what can we do? Like, one thing is like meditation, daily exercise, keeping a positive thoughts and positive vibes. Yes, this is what we are doing as our profession, and we are doing in a good faith. But apart from that, what else uh, uh, we can do?
Dr. Shraddha, I can relate so well with you because I work in a cancer hospital, and Dr. Archana and Dr. Spandana, we all come from similar background, and we happens to us every day. And I also see one question: what keeps you going with this kind of situation? One thing I'll say, one thing which I learned from my seniors while getting into palliative care, or even otherwise, I think we should remember when we're practicing medicine, you may not do palliative care tomorrow, but you're practicing hardcore medicine, is that we have to accept our limitation. We cannot fight what we cannot change. So we have to accept a limitation. We cannot change the system. So our frustration when we see so many children dying, and we feel that a childhood cancer, they should not be dying, and the still children are dying, and like we feel responsible. The children are dying because of various reasons. The system, the child's, many other reasons that why children die in our country. So we can't change the system. But even with all the limitations which we face, and we are still, the little change we bring to their life, like what Dr. Archana did to this child and the family, what relief you brought to the family, that helps us to keep going. So that is one thing I would say. I've seen many families where we are telling the family all the time, you're dying, your child is dying, your child is dying. But what they do is, and after the death, they come back and they come all the way just to say thank you. If you are not there, I don't know what I would have done. I knew my child was dying, but your support, that was so helpful. That is one part of it. That is professionally accepting what we can do and what we cannot do, and then going with that. Second thing is, I would say, very important when you're dealing with death and dying, to create a team. You need to have a team. If you work in a team, talk to each other and share your team who work in a similar, who understands and work with you, not the team where you have people totally not agreeing with your views. So having a team is something which is, I think, which helps me a lot. When I talk to my friends, my colleagues, and my nurses, they are the source of strength for me. Many times the nurses, they come, when something goes wrong, they'll come and tell, no, madam, we did our best. I think I don't think we could have done anything better. It's so helpful when somebody says that. So having a team. Number 3, which I would say is, like you said, Dr. Shraddha, taking care of ourselves. Once if your working hours is 9 to 5, after 5 o'clock, I think we should just close palliative care or your work and go home and take care of yourself. Spend that time, your alone time, taking care of yourself, doing things which gives meaning to you and give peace to you. So that is the very important part. I think we don't remember to do that, and we all agree somewhere, but we don't do it. But once again, reminding ourselves that we have to do that, and never take your distress to your family. I always say that. This again I learned. Your family will not understand when you describe this child dying, and they'll say, please don't go to work. Rather do some happy things. Don't go to palliative care. So, and you create more distress among them because they don't understand. They feel very concerned about you. So keep your distress, keep to your team. And sometimes we need help from professionals also sometimes when we reach the verge of real burnout. So that's why that's what I would say. Yeah, taking care of death and dying is not very easy, but when you do it well, the peace you bring in their life, sometimes that enough is to keep us going. That's all I would say. In the interest of time, I'll come back to this discussion with one more case presentation, and we'll come back to the similar. We'll come back to Asra. I want Dr. Biplav. Can you say hello? Hello, Dr. Biplav.
Yes, ma'am. He's coming.
So, Dr. Biplav, if you can just say hello, I'll present your short case which Biplav is going to share with us, and then we'll come back to continue with the discussion Dr. Shraddha and others initiated.
Hello, good afternoon, everyone.
Hello, Dr. Biplav. Thank you very much for agreeing to join us. So if you can, I'll share the screen and help you with the projection of slide. Over to you, Biplav.
I think it's showing a different slide, ma'am. Now it's okay. So a very short presentation about Asra, name change. She's a 5-year-old female diagnosed as relapse of ALL and was under chemotherapy for protocol of ALL relapse protocol. So very short on what was happening with her for the last 1 week prior to the day I'm going to describe, was that she had multiple episodes of admission for and multiple transfusions for anemia, thrombocytopenia. She had few episodes of epistaxis and also admission for neutropenia with antibiotics. She had some amount of mucositis. There were multiple complaints, and there was regular interaction with pediatric palliative care team. There were regular communications. A good amount of communication was already done about the diagnosis, prognosis, and the nature of the disease of ALL relapse, and everything was there was a considerable amount of rapport already built with and trust built with the team of pediatric palliative care. Next slide, please, ma'am. So on the day of which I'm describing, so there were multiple issues. Some of the issues where the one important was seizure. So the previous day, the platelet counts was 5,000. Patient received transfusion of platelets. Despite that, she developed seizure since 2 a.m. at that night. There were bilateral seizures, mostly on the right side, tonic-clonic type. And it was not, they were not well controlled with the medications which were being given. And she also had developed shortness of breath, gradually progressive with severe signs. As you can see, severe signs of respiratory distress. And so the observational grading which was done was severe. Parents wanted oxygen for their child for that shortness of breath, thinking it would help with the breathing. But as it went on, initially she was put under oxygen for quite some time. And later on, the child herself withdrew and refused oxygen which was being given. Next slide, please. Another issue was noisy breathing, which was we generally tend to call it death rattle, which in itself sounds sometimes frightening to people, and it was of particular distress to the parents. And in between, she also developed irritability, which was occasional. She was restless and irritable. On assessment CAPD scoring, it was more than 9. And of course, as I said, there was epistaxis. However, it was not severe. It was only mild. But it was of particular distress to the parents, seeing child have some amount of bleeding from nose despite all their efforts. So the father wanted to go to blood bank to bring platelets from time and again, because he felt that could help her. And apart from that, there was gradually, slowly decreasing saturation and no intake of food or liquid and decreasing urine output. Next slide, please. And of course, there was parental emotional issues and distress. Parents well understood about their daughter being at the end of life as they were regularly communicated about this. And the difficulty in breathing and noisy breathing at that day was aware of particular concerns and significant distress for them. She had, as I told, she had received platelet transfusion the previous night. Father wanted another platelet transfusion, thinking it would help in bleeding and thus maybe in seizure also. However, after a patient timely communication with the palliative care team, the father and also the mother agreed to spend more time with the daughter rather than going searching here and there for blood products. They wanted to hold their daughter, which they did, and also they sat together and cried together with the father and mother. Next slide, please. So upon these assessments, our goals of care were symptom control. We wanted to control the symptoms as much as possible, seizure control, other symptoms management like shortness of breath, noisy breathing, irritability, and bleeding. We wanted symptom control, impeccable symptom control up till which was possible, and of course best possible comfort care, which includes general comforts, general measures of comfort, as well as comfort due to the distress from the symptoms, and of course parental counseling and support, decision on place of care, and decision on place of death, and care plan if they wanted to go home. Next slide, please. So what was done during the end of life care when she was still in the hospital? Anti-seizure medications were done. So I don't want to go into the details of exactly the medications, but anti-seizure medications adjustment were done, few were added, and seizure, there was a brief control of seizures, but with recurrence in between, but the parents were a little satisfied that seizure stopped in between for considerable period. Parents were again counseled about terminal condition, bodily changes at that time, like decreased urine output, the child not drinking or eating, and decreasing consciousness level, all were part of the process of dying. And that things which were being done to provide relief and comfort to their daughter during the period of end of life. Next slide, please. We also used curtains. So it was ICU setup. So providing a full privacy was not possible, but we tried some measures to provide privacy, like we provided curtains. The lights in the sides of the bed were made dim so that it did not disturb the child much. And the parents were encouraged to keep her in their laps. They kept her in their laps, father and mother taking turns. And as everyone agreed that patient did not want to continue oxygen, so it was discontinued. The saturation probe, which was being kept after the oxygen was discontinued, father agreed to take the saturation probe out and not continue putting it into his daughter's toes. And father was also advised to wet the lips with wet gauze piece, as he was concerned about dryness of lips. And then as per initial discussion, they wanted to continue care at the hospital. Next slide, please. So during this, injection morphine was given, and it was given in start with to help in shortness of breath, and it was repeated as required. We gave hourly dose for a few doses, and then for the noisy breathing which was present, we gave glycopyrrolate. The IV preparation was drawn into a syringe and 2 drops given buccally. Also, manual handled mucus supply, gentle suction of the oral secretions which came out was also advised and done. As she was irritable and restless in between, so 1 dose of haloperidol was given and advised for SOS. For nasal bleeding, gauze which were soaked with adrenaline and tranexamic acid were used locally, which helped a little bit. And these were dark color clothes were used to rub out and to gently help in the bleeding locally, but not vigorous cleaning, and all those were not done. And of course, repeated counseling and reassurance was done. So later, upon rediscussion, parents then they wished to take the patient home, as they felt there would be other relatives at home who would help take care of the patient as well as patient's mother. And they also said they had a paramedic relative who would help with administration of medications at home if explained properly. So we made a plan to send the child home for end of life care, and for that we helped with our team prepared the parents how to take care for her at home. So they were advised on how to give medications, what medication was for what symptom, and how to give them. As we all know, these patients with chronic diseases, the parents have had many exposures, many hospital admissions. they most likely have many experiences on how to give medications, word for word. So it was not very difficult to explain, but we explained, we labeled the medications properly and explained which to be given in what indications. So tablet morphine was mixed with distilled water, labeled properly, loaded in a syringe, and advised for oral use if possible. There was a subcutaneous line in situ which was not removed, and it was advised that if there is severe pain or increased shortness of breath more than which was present, it could be given injectable formation could be given, and dose was explained, labeled properly. Glycopyrrolate was similarly given for buccal use, 2 drops if there is increased shortness of breath, along with handled gentle suction. And injection midazolam subcutaneously was advised to be used for seizure. Next slide, please. And we also prepared a kit for helping with the bleeding, which was a particular concern. So dark clothes, the cotton clothes, not a big one, but small pieces of clothes which could be used were provided. As dark clothes is has been mentioned 2 or 3 times in these slides, because clearly visible blood stains in bright clothes might in themselves be a cause of parental anxiety and distress. So dark clothes is advised. Disposable gloves were given. Tablet lorazepam was given for sublingual use if there is for increased anxiety associated with shortness of breath and also for seizure. And adrenaline and tranexamic acid to be soaked in clothes or gauze and used locally if nasal bleed was there. This was only given in the fact that there was a paramedic who would be able to do all this and provide at home. Gauze pads were provided, and waste disposal, a dark colored waste disposal bag was provided, which they would utilize in disposing all these things with blood stains when required. Next slide, please. The next day, home care team support. So next day, early in the morning, father was called by our social worker of our team, and to learn about the child's condition. And after discussion, the home care visit was done by pediatric palliative care team composing of pediatrician, pediatric palliative care nurse, and counselor. And more other items like gloves and medicines were provided more than what they were provided the previous day. And family members were, again, we took time to sit down, talk to them, listen to any concerns if they had, and they were encouraged to be together with the child and support each other. They were also advised, before leaving, they were also advised to call us for any concerns or queries if required, and also if they wanted to express any feelings. Later, we found out that the child passed away in her mother's lap at home with minimal suffering. This was done, we found out this because we called the father the next day. We called in that number the next day, and he described it in that way. So after that, we have a plan to make a bereavement visit in home in 2 weeks' time. Ma'am, I think you are muted.
Sorry. So thank you very much, Dr. Bipla. Wonderful wonderful example of how providing end-of-life care in the hospital followed by home. So we had enough time to this, and also the care transition. If you notice how much effort has gone into providing this care transition and care coordination between the local GP, home care team, hospice team, and one designated care social worker coordinating the whole thing. And this is also an example of, see, if you notice, this child had initial frequent crisis. And that's the time it was felt this child needs total, and the child is declining condition, and very soon the child will need end-of-life care. So like, remember my graph I showed you? So this is a classic example how this child started with frequent crisis and hospitalization, followed by real rapid decline and end-of-life care. It's also an example of how symptoms were managed. Remember that if the symptoms are not managed well, again, they think they have to do more, and they go doctor shopping or they go to some hospital. Crisis plan, we always make it a point to manage crisis. End of life care, always you expect crisis. So if you prepare well in advance, depending upon the child's disease condition, if you anticipate what all crisis child may have and make a care plan, it's so much well managed by the family as well as a health worker. So it's not a surprise. The child suddenly starts breathing, bleeding, or seizures. It should not come as a surprise. We should anticipate crisis and then make a plan. And that is an essential part of any end-of-life care. And one more thing I want to highlight here is that the subcutaneous route of administration. This is something we use very frequently. It's a universal way of administering medications and hydration in end-of-life care situation, both in adult and children. Very comfortable, very easy to administer, and well tolerated by most families. And most medications which we described so far, we can administer by subcutaneous route of administration. So this is one more thing which we learned in today's presentation. So we have few minutes left. Over to you, Spandana, and okay, I see one question. I'll take this and I'll hand over to you, Spandana. So bereavement counseling. Okay, so what we do in bereavement counseling, typically, generally, we have one general bereavement counseling where what we do is when all families who are under our care, when they and the loved one passes away, we make informal either visiting them, calling on them, phone call, sending a postcard, or calling them for memorial service. All these things we keep doing, and while doing this, we closely monitor how the family is doing. So this is the general bereavement care we do. And while doing that, we have trained our counselors to ask some specific questions. To look, what we are looking for while doing all this is that how well are they coping with the grief. The grief can be normal grief and anticipated grief, complicated grief. So what we look for is that, is the family coping well with grief or not? And are there any signs of complicated grief that the family is encountering? Family means mother, parents, siblings. Very often see siblings experiencing complicated grief. So closely monitoring that. And if they're doing well, we follow them up for some period of time, say 6 months, and then we leave them because their life goes on and they move on. But if you sense any signs of complicated grief in the family, then we go more deeper into it and look at what exactly is happening in the family and see how best we look at their mental health issues and support them. So this is what typically we do in bereavement support counseling for all pediatric patients. Spandana, you had done recently some grief training abroad. Would you like to tell us more about grief and counseling, grief and bereavement? What you
Yes, ma'am. I think most of the times the work begins even before the death happens, having that relationship, because once the death happens, we try and not introduce the family to new people instead, but the same team is trying to follow up so that the family knows it is authentic wherever it is coming from. And I think the other thing we do have to remember is resources. In India, as you said, most of the times we stay in touch because MNJ and Nilofer are tertiary hospitals. Most of the times they go back and it is through phones. But if they are from the same place, it is good to meet them together. And there is this whole concept of sending greeting cards or letters with personalized messages time to time, having parent support groups. Again, these are very highly, what you call, very specific interventions. So I cannot just come in blind and say, hey, I'm going to do a support group, because sometimes things can get very complicated and people need training to do these things. So parent support groups, sibling support groups, and these are all some things people are doing. And also access to printed material, books, online, based on, again, the situation of the family. These are some things that exist, ma'am.
Thank you, Spanna. There's something which we recently, ICD-11 and DSM-5 classification. In DSM-5, they've introduced what they call it as prolonged grief disorder, and in which they're given a criteria. So we look at these things. If you find they're fitting into this, probably they're having prolonged grief disorder. It's a kind of, they found it as another new entity. And a lot of debate around that, but that's something which is really recently introduced, and there's something people recommend to actively follow up on all of these families, because these families, remember that losing a child is a condition where we expect high prevalence of complicated grief. The families or the siblings experiencing this is they are the high risk for complicated grief, and especially if the child had a very terrible experience, a terrible death, prior to death, the family witnessing a lot of suffering in the child, they are very prone for complicated grief. Over to you, Spandana. I think it's time, and if any more.
Yeah, I think the time is up. I think one other thing that was brought up was self-care, and people said it is very tough. I just want to say that, as Gayatri ma'am said, just to remember that at the end of the day, modern medicine is still limited and we are doing our best. And I think palliative care, as you have seen through the demonstration of both the cancer and non-cancer, there is no such thing that there is nothing more to be done. I think that is where a lot of difficulty comes for doctors and parents when we say something like nothing more to be done for your child right now. And both Dr. Biplav and Dr. Archana have demonstrated that there is always something to be done for the child and the family. And by doing that, I think we are taking care of our children, families, but also of ourselves, because we know we gave them the best. The problem comes when we say there is nothing more to be done and we send them away somewhere. I think that's where a lot of distress comes from. And yeah, oncology, I know a lot of morbidity, but if you can imagine, in palliative care, this is what we do day in and day out. I'm not saying palliative care is for everybody, but if you can imagine, palliative care is in a way just like intensive care on the other side. So palliative care as intensive care is what we are trying to say, because there is a lot of aggressive comfort measures that we take. So I think we would like to end the session on these thoughts that please do take care of yourself. Whether we are practicing palliative care or not, we are all going to see children with end-of-life situations. And preparing the family, making sure that we are doing the best possible medicine that is there, and also trying to be as present as possible with the families and the children. I think these are very important for us to continue this work. Gayatri ma'am, Dr. Archana, Dr. Biplav, any closing comments before we leave?
No, thank you. And I think there's a post-test questionnaire. I don't know when it will be shared.
I'll be posting it in the WhatsApp group, ma'am, shortly.
Sure. Thank you. And thank you, Vanilla, for all this background help.
Thank you. There is one question in the chat, which someone has asked about if you can share the details about how to start a new palliative care unit in a medical college. So the last 3rd week of October, we have a session on this, how to start a palliative care center. I think it will be done by the faculty then. Hope it's all right. I think one of the doctors have asked the question.
I think we'll bring back this discussion in those sessions. Yeah, it's
Yes.
Integrating into the medical college. Yeah, it's very important.
Yes.
Yeah. Thank you.
Thank you, everyone. We will all see you in 1 week time. And Vanilla will be posting the post session quiz. Kindly answer that. Thank you.